If you have cubital tunnel, you might have a compression here at a very particular nerve. It's your ulnar nerve, and you're considering, do I do therapy? Do I do surgery? What kind of surgeries? Well, my name is Huang. I'm an occupational therapist and certified hand therapist, and I did other videos talking about what cubital tunnel is, talking about what you want to pay attention to before surgery, after surgery, and someone left me a comment regarding like what would I recommend. So one of the things that I do here on my channel is that I try to educate you if you're looking to make decisions around, what's going on with your hand and arm injury, what kind of surgeries do you need. But one thing I try not to do is to tell you what to do. I only tell my patients what to do because I have worked with them. I know their past medical history. I know what kind of injuries they've had before, just because I've worked with them, right? So what I want to do in this video here is just to educate you so you have a real clear understanding so that it can guide you towards a decision. The decision to have surgery is really between you, your surgeon, and your therapist. If you don't have a trusted certified hand therapist, I would really recommend maybe finding one, because it's very important to be very clear on what could be wrong, right? So this is what I do for my patients because I get to know them. And I've worked with people who've had simple releases all the way to having the more complex transposition, meaning they move the nerve around muscles. And that is a lot more complex. So let me kind of break it down a little bit for you. If you have cubital tunnel, it used to be where they would just splint you, say, oh, you don't need to do anything. When it gets worse, we'll do surgery, because they never really thought that therapy was as beneficial. But now with more experience, I find that if I can catch someone and I could figure out why they got cubital tunnel in the first place, why do they have a compression at that nerve level, at the elbow, we can figure it out, work through it, and avoid surgery altogether. Now, I have a friend who back in my early days, I was working with tons of surgeons. So I was like, yeah, go have the surgery, girl. Like, you're going to be good because the recovery is really easy, not a problem, and you don't need a ton of therapy. Well, fast forward 3 years later, she started having that problem again. And I'll tell you what, one of the reasons why she ended up having that problem again, even after a release, is because we never dealt with that root cause problem to begin with, because we were so quick to rush to surgery, right? So conservatively, therapy can help. So when think about therapy, think about what you're actually doing in therapy. Are they looking at your neck? Are they looking at your shoulder and working on your shoulder? And are they looking at your elbow? Because that's where it gets stuck. It's getting stuck along the way. It's getting stuck somewhere here, or here. One of the things that I have found to be very effective when working with anyone with cubital tunnel is I work the shoulder. The shoulder is weak somewhere. You got to find where your weakness is. I find a lot of people have tricep issues, and the tricep isn't necessarily weak per se. It's just in comparison to other muscles, it's weak. It's not doing its job. It can also be tight. So one of the things I love doing is just making sure we're working with the tricep. Now, the tricep is in its longest form when the shoulder is up and the elbow is bent. Your tricep is super long. It's shortest when the shoulder is back and the arm is straight. That's when the tricep is at its shortest. And so you want to be able to work the tricep in both its ranges, and then make sure that that muscle works well in comparison to the biceps and, of course, all the shoulder muscles. All right, so definitely make sure you're looking at your neck, you're looking at your thoracic spine, and then how that shoulder moves before you just say therapy doesn't help. If your therapist didn't do that for you, then find a therapist that will, right? Find a therapist that will. A lot of times I find that when you're working within that insurance restraint, if it says elbow, they're going to be right at your elbow and they're not necessarily going to look somewhere else. So just find a trusted therapist willing to look for the root cause of that particular problem. Now, if you've tried all those things and you're like, Huang, it still bothers me. I can't take it. I'm okay having the surgery. Great, have the surgery. So you always want to go from easiest to hardest. Endoscopic release is the easiest, and submuscular, right? Anything under anterior transpositions, right? So first you have a simple release, endoscopic release, right? And then there's a in situ decompression. And then you have medial epicondylectomy. That's a mouthful, right? Medial, I'm just gonna say ectomy. Ectomy means they're gonna shave something off. They're just shaving off a piece of that bone. And then you get into number 4, which is the transpositions with anterior transposition. So and then of course within the anterior transposition, there's the easiest of those as well. And usually in my experience, those are harder to recover, and it's usually recommended when I have worked with patients who have had major fractures to their elbow or something like that. There's other problems going on, and that's why that is being done. So you want to start with the easiest, and then if it doesn't work, go to the next and the next and the next, right? Your body shape also can play a deciding factor. You know, are you really, really skinny versus are you like chunkier like me, or are you a little heavier? If you are super skinny, some transpositions aren't as good for you because you don't got no meat there, right? You don't have any fat there to like cover up the nerve, and that nerve is always it's the most superficial. You can feel it between this knob, this is your olecranon, and then this is your medial epicondyle. Your nerve runs right here. That's your funny bone. So because it's very what we call superficial, meaning on the surface, it's not very deep, there isn't a lot of tissue to cover it. So the more things are just being like shaved and moved around and stuff like that, they're trying to put it under something to give it some cushion. But you put it under something, then it can get crushed from the muscles too. So there's a lot of different types of procedure. The endoscopic release is by far the easiest one. The in-situ decompression, cut to release the ligament. Good for those with mild weakness and sudden onset, mild abnormal sensory action potential, and intermittent numbness. Pros, it's easy recovery. Cons are there's a reoccurrence and sometimes it's not enough. An endoscopic release, which is the easier one, good results 92% of the time with mild to moderate pre-op symptoms, right? So most of the time people are going for the endoscopic release because it works 92% of the time. Details that I'm coming from come straight out of one of our biggest textbooks that we study for to become a certified hand therapist. This is the thing that I teach to other therapists as well, and how they can then help their patients make decisions around these types of problems. But you don't go from like having the simplest to being like, oh, let me just do this one time and then go shave some bone off, cut the muscle, shove the nerve through the muscle, because you do want to think about recovery time. But one of the biggest things that I talk to my patients about is I really talk about what have you worked on in the past? What has worked, what hasn't worked? Because if you have really great range of motion, and I always talk about people who are very loosey-goosey. So people who are loosey-goosey they're hypermobile. So they have a lot of mobility. Their arm goes past 90 degrees. Their shoulders go all the way up to their ear or even past their ear. Their knees hyperextend, meaning it goes, kind of a little bit more backwards. So you have a lot of movement, which means your ligaments that hold your bones together, it has a lot of give, right? So because it has a lot of give, it's going to rely on your muscles to hold that shit together, hold your joint together. So sometimes people who have cubital tunnel types of issues, they tend to be loosey-goosey people. People who come to me with a lot of various nerve-related issues that didn't get caused caused by an accident, a fracture, surgeries, they tend to have these chronic types of issues. They tend to be very hypermobile. So if you tend to be hypermobile and you don't get to the root cause of why you got this shit in the first place, and you can go down that rabbit hole of having surgery after surgery after surgery. So I have a friend of mine who had that endoscopic release. I was like, yeah, girl, go get that. It's easy, no problem, because that is what they tell you in the textbook. Now with more experience, I'm able to like help my patients get rid of it. And at some point I'll develop a diagnose yourself and do it yourself kind of program, but we're not there yet. But this is a relatively easy one, but you'll end up with the same problem if you have a tendency to be hypermobile, and then, you know, down the road, and it could be months, it could be years. My friend didn't have a problem until 3 to 4 years later. And then every once in a while, it'll kind of rear its ugly head. But if you know how to treat it, if you know what exercises, because your body falls into certain patterns because we do the same things over and over and over. Your body tends to fall into those patterns, and you have to figure out what exercise, what's the 1 or 2 exercises that your body needs in order to ensure that that doesn't happen. I have a lot of nerve tension types of issues. As soon as I have it, I'm like, okay, Huang, what's bothering me? And I go right to that exercise, I do it, and it's gone, right? I mean, you know, I have the benefit of knowing what the hell I'm doing, but that's how I think about cubital tunnel surgery. You always go from the easiest before you go to the hardest. The hardest really is any kind of transposition. Anytime they're carving out some bones, moving some muscles around, get to the root cause of why you have your problem and then make decisions around it. When I worked with a guy who had he fell and he crushed his elbow. They put his elbow together, he did really well, but because of the fracture and the plating and the therapy he had to go through, it was, you know, it irritated his nerve. And so, yeah, and because of how it was broken and where it was broken, it really exposed that nerve. And so he ended up having a submuscular anterior transposition, which is one of the harder ones. But that's just because he needed that specific one. And I worked with him, the surgeon, and, you know, we created a game plan to make sure that, you know, what was in his best interest, to get him at least some great results. But if you don't have an accident like that, you got to find someone you trust to then help you consider what are your options. But my go-to always is get to the root cause of the problem, and then if you can't do it and you know in your heart, in your gut, you tried everything and it doesn't work, then do the surgery. Let me know if that helps you. If you like this kind of video where I'm kind of going over my thought process, let me know and I'll make more of them for you. All right, type it in the comments below. All right, thanks. Until next time.